Welcome to this webinar brought to you by Fujifilm Sonosite. This audiovisual presentation is part of the Sonosite Institute webinar series and is intended to be educational. My name is Sachita Shah, and I am an Associate Professor of Emergency Medicine at University of Washington School of Medicine, and I'm speaking to you about a favorite topic of mine, approach to dyspnea in resource-limited settings. This talk is going to be focused on helping you as a clinician, who may be practicing in a resource-rich or a resource-poor environment, learn how to use ultrasound to distinguish top causes of dyspnea. We will do image review and mention a bit of supporting evidence and data, but we will not delve into exactly how to perform each scan, since there are fantastic tutorials available through the Sonosite Institute and other avenues for learning each type of scan. So today we'll cover background and evidence, the blue and false protocols, and then I will introduce a cardiopulmonary ultrasound scan for use in limited resource settings. We will do some case-based visual diagnosis and discuss the use of ultrasound in the ongoing management of dyspneic patients after the initial diagnosis. And we will review pitfalls and a quick summary before we close. So first, let's review the literature for use of ultrasound in dyspneic patients in high-income countries. This article was published in Chest in 2015, and it was comparing two commonly used protocols. The blue protocol, which was first introduced by Dr. Lichtenstein in 2008, as well as the false protocol. The main goal of the blue protocol is to help distinguish COPD and asthma, in which you'll see both A lines and lung sliding, from dyspnea from pulmonary edema, or CHF, in which you'll see B lines and lung sliding. Pneumonia can have many appearances, which we'll see later, so in my opinion, this protocol isn't quite focused on assessment of pneumonia. And the main reason to use this protocol is when your top two diagnoses are either COPD and asthma or acute decompensated heart failure. This is a highly accurate protocol with sensitivities in the 80 to 90, high 90% range. And similarly, another great protocol is the false protocol. This tool is helpful in assessing the cause of shock by adding a focused cardiac ultrasound to the focused lung ultrasound introduced in the blue protocol. The focused cardiac ultrasound here assesses for right ventricular size in comparison to left ventricular size, as well as assessment of effusion and tamponade. The blue and false protocols are great. They were developed for use in high-income countries with sensitivities pitted against CT scanning. Unfortunately, this is not usually possible in low-income countries with limited access to advanced imaging modalities such as CT, and the sensitivities may be different in areas in which large portions of the population have had prior exposure to TB, which can lead to scarring. In addition, most studies on dyspnea, including these studies deriving these protocols, have not included children, which comprise a significant and vulnerable patient population. So to care effectively for all patients presenting with dyspnea in remote settings, I would suggest an effective ultrasound screening must include not only the typical blue and false type scans, but also look something like this: a pairing of a focused cardiac ultrasound with a focused lung ultrasound, and then a specific pediatric focus on pneumonia. I also put in yellow here, avoid the pitfalls of assuming the sensitivity is the same for using all of these different types of scans all over the world. So let's start with a patient, a case. A patient arrives to you via ambulance with dyspnea, and let's say you're not in the US. You are in rural Rinkwavu, Rwanda. So the age of the patient is 85, so they're elderly. The SAT is 80, which is usually a bad sign when the SAT is less than the age. The respiratory rate is 40, they're tachypnic, and their temp is 37.8. This is almost a fever. And 10 is the number of seconds it takes for you to grab your ultrasound and head to the bedside. It doesn't matter whether you're stateside, in a city, or in rural Rwanda. If they're in respiratory distress, as the clinician, you're quickly building a differential for their shortness of breath in your mind. Now, this list is not comprehensive, but you know the diagnostic dilemma is that we're pressed for time in acutely dyspneic patients. Ultrasound can help us by discerning which of these top causes of dyspnea the patient has. And as you can see, it can be useful in many, many different types of diagnoses. So let's discuss the cardiopulmonary ultrasound exam components. In the focus cardiac portion, we're looking at chamber size, specifically right versus left ventricles, and then the presence of pericardial effusion and size of effusion, including assessment for tamponade. And we're also looking at left ventricular systolic function, specifically to get a sense of whether the patient's shortness of breath is caused by acute decompensated heart failure. We're not going to measure ejection fraction, but rather get a global sense of the left ventricular squeeze. For the focused lung ultrasound, we are looking at lung sliding. We are looking at B lines. Now, when we're thinking about B lines, we're going to assess for diffuse normal comet tails versus excessive B lines, which is more than 3 per field. We're also looking to see whether we see A lines. A lines can be a sign of normal, but it can also be a sign that the shortness of breath is due to COPD or asthma. We are going to do a specific pneumonia screening, and we can discuss the benefits of listening in all areas and then only scanning with your ultrasound machine in areas of focality with abnormal lung sounds versus doing a diffuse screening if you are unable to hear good breath sounds throughout. We will also look laterally and inferiorly in the reclined patient for pleural effusions. These graphs are from the WHO. They show the top causes of death in high versus low-income countries. Whether you're in a high-income country or a low-income country or anywhere in between, patients may present with dyspnea and be dying of one of these top causes, which a quick bedside ultrasound can help you diagnose. For example, acute decompensated heart failure in the setting of ischemic cardiac event, versus pneumonia, which is a leading cause of children worldwide, and it's the top cause of death in low-income countries for adults and children. Both of these diagnoses can be quickly identified using bedside ultrasound. Let's go back to our patient. So she's in rural Rwanda, and to set the stage, we're in a low-income country. So on exam, we find she has decreased breath sounds and lung sounds. Based on her demographics and what we know from this graph, we'd suspect she has a lower respiratory infection. So we shoot an x-ray, and her chest x-ray shows an enlarged cardiac silhouette and possibly an infectious process over there in the right middle lobe. The differential diagnosis for cardiomegaly, or enlarged cardiac silhouette, is often binary. Either there's heart failure with enlarged actual chambers of the heart, or we have a normal-sized heart inside a large pericardial effusion. So let's review some images of what we might find if we do her cardiopulmonary ultrasound protocol in a standardized fashion and see why she might be short of breath. So here are our two options. On the left side of your screen, you'll see a normal appearing left ventricular squeeze in a heart that is surrounded by a pericardial effusion. That can cause enlarged cardiac silhouette. On the right side of the screen, we see a parasternal short view of a left ventricle that's not squeezing as well. Perhaps if this was her scan, her shortness of breath may be caused by acute decompensated heart failure. So let's start with the cardiac portion and review what it would look like if she had abnormal septal bowing or right-sided ventricular enlargement, such as in a PE. We will review what it would look like if she has pericardial effusion and also heart failure. So the normal parasternal long axis view is performed with the probe lateral to the sternum and the marker towards the patient's right shoulder. This image is in the cardiology orientation with the screen marker on the right side of the screen. A normal parasternal long axis view is highly predictive of no cardiac pathology contributing to the dyspnea, and it's our go-to view for assessment of all three of the cardiopulmonary ultrasound cardiac components at first, with the other views supplementing as needed. So when we're looking for signs of right heart strain associated with a large PE or cor pulmonale from some other pulmonary process, we're going to look at the right versus left ventricular chamber size. Now, we have an increased risk of PE and DVT, even in ambulatory patients if they're HIV positive. And there's also an increased risk internationally in hospitalized patients in low-income countries because there aren't usually leg squeezers and anti-embolism protocols in place with the sub-Q heparin and things like that. So here's an example of an apical four-chamber view showing paradoxical motion of the septum. In the center of the screen, we can see the intraventricular septum is kind of flip-flopping side to side, and this is suggestive that we have high right-sided pressures. Here we see the right heart appears quite plump in comparison to the left. The diameter of the right ventricle should usually be smaller than the diameter of the left ventricle, and at most we allow a 1-to-1 ratio between the two. But here we see at times, especially when the right ventricle is filling, it is actually larger than the left, with abnormal bowing of the septum suggesting higher pressures in the right ventricle than in the left. Now, how do we tell if this enlarged right ventricle is due to long-standing, here's another example of an enlarged right ventricle. How do we tell if this right ventricle is enlarged due to long-standing pulmonary hypertension or something quick, such as a pulmonary embolism? For that, we can look at the right ventricular wall. If the right ventricular wall is thin, that suggests an acute event, such as a PE. However, if it is thickened, that suggests a long-standing event, such as slowly increasing cor pulmonale. If you suspect a PE, especially if you see an enlarged right ventricle, it's also great to add in a quick scan for DVT looking for clot. You can do this using a 2-point compression technique in the femoral and popliteal veins. The next part of the cardiac portion of the cardiopulmonary ultrasound protocol is to look for an effusion. Blavis published a study in Academic Emergency Medicine in 2011 looking at 113 patients with undifferentiated dyspnea who underwent a focused cardiac ultrasound, and he found that 14% of the patients had pericardial effusions, 4 of which were classified as large. We recently published a similarly designed study of this CPUS protocol that I'm describing here today in Critical Ultrasound Journal, just published this month actually, and its performance in Haiti. We found that 8% of our patients had moderate to large pericardial effusions as a cause for their undifferentiated dyspnea. So, effusions of the pericardium from TB and cancer can be fibrinous, making them harder to see. Here's one, for example, from TB. And see how hyperechoic this is? It's almost difficult to distinguish the pericardium from the fibrinous effusion. Now, effusions can cause dyspnea, and if mismanaged with inhalers for presumed COPD and asthma, which speed the heart rate and allow less time for filling and decrease each stroke volume with each heartbeat, or with Lasix, which decreases the venous return and preload, or with positive pressure, which decreases your preload, all of these kind of misactions can push the patient with a pericardial effusion into tamponade, which is seen here with diastolic collapse of the right heart and a large circumferential effusion. So our goals with the CPUS exam to assess LV function include grossly estimating the LV function, not to calculate the EF. In our study in Haiti, and also the Breathing Not Properly study, shows that approximately 40% of patients, so a high proportion, presenting with dyspnea may have LV dysfunction. And the goal of the LV function is to grossly estimate whether the patient's LV is at such a low function that this could be the cause of their dyspnea. Heart failure is quite common in low-income countries, as it is all over the world, and it's important to use a couple of different cardiac views. We suggest the parasternal long axis and the parasternal short axis for best interpretation of this portion of the scan. So diagnosis of acute decompensated heart failure requires not just echo, but also putting it together with the clinical picture. Here we see a parasternal short axis view in the left upper area of the screen, showing slightly decreased left ventricular systolic function, as well as paired with lung ultrasound in the lower left-hand part of your screen, showing B lines. And on the right side of your screen, you see an inferior vena cava that's looking quite plethoric and plump. These 3 scans together, this triple scan of the heart, IVC, and lungs, was first described in the literature about 5 years ago as the CLUE protocol, and has since been shown in several studies to correlate very well with the presence of acute decompensated heart failure. So if you see reduced LV function, we suggest adding the IVC scan. So here we see 2 potential causes for somebody's shortness of breath, an effusion, but also LV function that doesn't appear normal. If we look at the free wall of the left ventricle and how it's squeezing in comparison to the interventricular septum, we'll notice that with each heartbeat, those walls are not really coming together. And also that mitral valve, the anterior leaflet, doesn't actually come up and smack the septum or get close to it like it should in a normally functioning heart. So that movement of the anterior leaflet of the mitral valve in proximity to the septum can be measured as the EPSS, or E-point septal separation. This can be measured in real time or with M-mode, but the exact measurement is variable depending on the literature. Separation of more than 6 to 7 millimeters has been described as suggestive of LV systolic dysfunction. There's a great article published in Journal of Emergency Medicine in 2014, and the title of which is E-point septal separation, a bedside tool for emergency physician assessment of left ventricular ejection fraction, showing that the EPSS actually is a good tool for assessment of acute decompensated heart failure. Now let's move on to the lung portion of the CPUS exam. We used to think that air was our enemy in sonography and that the lung just got in the way, but the field of lung ultrasound has expanded and it's proving to be a sensitive tool for diagnosis of many pulmonary conditions. So what we're looking for in the lung portion of the CPUS exam is lung sliding, B lines versus A lines, and if we're suspecting a pneumonia, we'll discuss how to screen for that. We're also looking for pleural effusions, and we're going to sneak a peek below the diaphragm to look for ascites as a compressive/obstructive cause of dyspnea. So normal lung sliding should be evaluated in the supine patient in the anterior chest, searching in 2 to 3 different rib spaces. Now, if the patient is sitting up, a small pneumothorax may be apical and may be missed, so we do suggest the patient being supine if they can tolerate it. What we see here are the 2 hyperechoic ribs on either side of your ultrasound screen, and then just deep to them, running horizontal across the screen, is a shimmering white hyperechoic line, which is moving, which is the sliding of the visceral and parietal pleura up against each other when they're separated by just a tiny bit of fluid. In contrast, in a pneumothorax, what we'll see is that bright white line does not move. That is just the parietal pleura, and it's separated from the visceral pleura by a whole lot of air, which is the pneumothorax, and that's why you don't actually see movement within that line. You don't actually see lung sliding in the setting of a pneumothorax. Now, lack of sliding can be seen in pneumothorax, but here I'd like to warn you that in TB endemic areas, this may not always be a pneumothorax. We can see lack of lung sliding in patients with severe TB who are pulmonary cripples from their TB. We can also see it in patients who are pulmonary cripples from even COPD, in that they have many, many blebs, so they have a lot of areas where they're not sliding. So usually you'll still see comet tails in those cases, but you don't see that here because this is actually a pneumothorax. So now that we've done lung sliding, let's move on to A lines versus B lines. We're going to look in several rib spaces, anterior and laterally, for A lines versus B lines. Here's an example of what A lines look like. They are reverberation artifacts of the normal pleural line seen at regularly spaced intervals deep to that bright white pleural line that we can see just deep to the ribs. In contrast, B lines, here's an example of B lines. These are downwardly emanating artifacts from the pleural line that go all the way down to the bottom of the screen, and these emanate kind of horizontally. I think that they look like flashlights shining through water. And when we see 1 or 2 of these, it's no big deal, it's considered normal. But when you see more than 3 B lines per rib space, and you see it in multiple spaces, this can occur with what we call alveolar interstitial syndrome. And this happens with any alveolar process, such as pulmonary edema, most commonly, but it can also happen in hemorrhage or really anything clogging up the interstitium. So I've seen this in miliary TB as well. We often use this, though, to evaluate for pulmonary edema in the setting of decompensated heart failure. We can see focal B lines in areas of pneumonia, so we'll move on talking about that next. So now, if pneumonia is suspected clinically, it's worth a conscious effort to look for pneumonia on lung scan. So the WHO recommends diagnosis of pneumonia based on a clinical scale, which is essentially based on respiratory rate. So we may be overtreating a lot of tachypnic children worldwide for pneumonia. Now, a recent study published in February 2016 in Chest by Dr. Sung and colleagues shows the feasibility and safety of substituting lung ultrasound for chest film when diagnosing pneumonia in kids. And this was a randomized controlled trial. So this figure is taken with permission from Dr. Sung. and it shows findings in pneumonia on ultrasound. Now, panel A is a normal lung ultrasound showing A lines, and then panel B and C show these hyperechoic speckled areas deep to the pleural line within the parenchyma, which are considered air bronchograms, and it's kind of little air bubbles trapped inside a consolidation. Panels D through F show another finding of confluent B lines, where the B lines come together in just kind of a wash of hyperechoic linear areas that are thicker than a normal B line. They're wider, and they emanate downwards from the pleural line. And these can be seen in more viral pneumonias and bronchiolitis. Next, we'll see a patient from Rwanda, and here you can see in a moving video the hyperechoic speckling, which is the air bronchogram, and this is a patient with pneumoconiosis from working in the mines. So next we have a patient who is HIV positive and unfortunately has a large hemorrhagic pleural effusion from his Kaposi's sarcoma of the lung. So pleural effusions can be diagnosed with ultrasound, and ultrasound can help to guide drainage of these to make them safer, especially in low resource settings. The identification of the pleural effusion doesn't tell you whether it's bloody from, for example, malignancy, or Kaposi's sarcoma in this case, or if it's more straw-colored, for example, from TB, but it can help you decide how big is this effusion, is it present, and can I drain it? So with identification of effusions in the pleural space, the diaphragm becomes visible, as we see it here. And TB effusions look very similar to non-TB effusions. They can be simple, or they can have fibrinous exudate. I'd also recommend taking a peek below the diaphragm to look for massive ascites, which may be a cause of obstructive dyspnea as well. So here's an example of a TB-related pleural effusion, which is septated. It's actually pushing, the effusion so large it's pushing down on the diaphragm and it is flattening it, and you can see all of these septations within it that cause kind of a reticular pattern inside the effusion. These are actually pretty tricky to tap, so it's good to know ahead of time what you're getting into. So that's the CPUS protocol in a nutshell. So for CHF flares, PE, COPD, and effusions, these are things that we're going to see worldwide. I also wanted to take a moment to review a bit about tuberculosis and how it appears on ultrasound as well. We think of TB as causing dyspnea by affecting the parenchyma, for example, miliary TB, which will just show a lot of B lines because it's an alveolar process. But TB causes many things in many different organs. It's the great mimic. Long-standing TB, where patients fail multiple rounds of therapy, can cause chronic blebs and even chronic pneumothorax. And in these patients, for example, here are some chest films from a TB hospital for XDR and MDR TB patients in Maseru, Lesotho. We can see lots of blebs, chronic scarring, and focal consolidations, among other problems. So what we see here is it's no wonder that these patients have any lung sliding with all of that pleural scarring. Some of these patients had blebs, and then they've popped these blebs, and then they have acute on chronic pneumothoraxes. So this patient population is particularly tricky to ultrasound. If you're not sure about lung sliding, occasionally M mode or even color, as shown here, can help you see subtle movement deep to the pleural line. I also wanted to mention briefly that ultrasound can play a big role in the management of patients with dyspnea after you diagnose them. So, for example, procedural guidance for thoracentesis or pericardiocentesis can be used under ultrasound to make the procedure safer. New data suggests that recruitment maneuvers can be visualized using ultrasound, and you can use ultrasound to check for reinflation in areas of focal collapse in ventilated patients after you change their position. And then, of course, the falls protocol also suggests that you can fluid resuscitate, for example, a septic patient, and then keep checking the lungs to balance out with causing pulmonary edema due to too much fluids. So you can resuscitate until B lines develop and then stop. So these images are used courtesy of the WWAMI Institute for Simulation in Healthcare and are part of a larger video training on ultrasound for thoracentesis. But I wanted to show you that ultrasound for thoracentesis guidance helps prevent complications. And I love teaching this internationally because the complications are even more concerning if it's difficult to get a chest tube for pneumothorax or a surgeon for a bleeding liver puncture due to errors in needle placement. So ultrasound can be used to locate the diaphragm, which can actually be very elevated in someone with a TB effusion because they often have coexistent ascites from disseminated TB, and it can help you choose a rib space that is just above it for maximal drainage. So watching the ultrasound through the different respiratory cycles of the patient helps the clinician determine the safest puncture site with respect to the diaphragmatic movement. And remember, post-procedure, don't forget to look for pneumothorax and lung sliding to make sure a complication did not occur. So in summary, the differential diagnosis of dyspnea is quite broad, but ultrasound can help diagnose many life-threatening problems, including acute decompensated heart failure, pneumothorax versus COPD flare, pneumonia, and then pleural and pericardial effusions, as well as PE. The CPUS exam components include a focused cardiac section as well as a focused lung ultrasound, and you'll want to scan both for all patients with undifferentiated dyspnea to gain clues towards which potential diagnoses fit your sick patients. Remember, lung sliding does not necessarily mean a pneumothorax, especially in a TB endemic area. And don't forget that the sensitivities for each of these exams are based on data from high-income countries, which are usually not TB endemic. All data needs to be taken with a grain of salt, and ultrasound is always operator dependent, but it can be a great tool for dyspneic patients. Don't forget to guide your needles using ultrasound, but always be prepared to use your physical exam as well. Thanks, and now I'm looking forward to taking your questions.